Symptoms develop quickly, and the individual typically has a fever, costovertebral angle tenderness, nausea, and vomiting, in addition to symptoms of cystitis. Lab studies include a CBC, which typically shows leukocytosis with neutrophilia. Renal function can be checked by obtaining a BUN and creatinine level. Urinalysis is done using either dipstick or microscopy. On microscopy, if there are white cell casts that take the form of the renal tubules, then it suggests that there's a renal origin for pyuria. That's because where there's an infection in the renal pelvis, there are also leukocytes, and they tend to aggregate and take the form of the renal tubules as they pass through. Finally, urine culture and susceptibility testing is always done. On a renal ultrasound, pyelonephritis shows up as a hypoechoic mass within one kidney, but it can also be bilateral. Now, sometimes imaging is needed with an abdominal CT scan with or without contrast. For example, imaging is useful in individuals who still have symptoms after 72 hours of antibiotic treatment. On a CT scan, acute pyelonephritis shows localized hypodense regions in one or both kidneys. Imaging should also be done if we suspect a urinary obstruction, like a stone, which can cause a decline in urine output and cause elevated creatinine levels. A CT scan can help identify a stone's location as well as signs of hydronephrosis, which often happens as a result of the obstruction. Alright, now empiric treatment can be started with oral ciprofloxacin for 7 days in individuals that can tolerate oral treatment. In individuals with nausea or vomiting, IV ciprofloxacin or IV ceftriaxone can be used for 10 to 14 days. IV antibiotics can be switched to oral antibiotics if symptoms improve. In individuals with urinary obstruction, broad-spectrum antibiotics like IV imipenem plus IV vancomycin are given for about 14 days. The antibiotic treatment is then adjusted according to the results of urine culture and susceptibility testing.